Hi, welcome back to Coding Matters. My name's Andrew. I'm delighted to be joined by Associate Professor Krish Sundararajan, who's the Director of Intensive Care at the Royal Adelaide Hospital. Thanks for joining us, Krish.
Thank you, Andrew. It's a pleasure to be here. Thank you.
And we'll be talking about intensive care documentation today. So let's talk now, this is specific to Central Adelaide Local Health Network. It's our top 5 under-documented conditions, but we're pretty sure from talking with colleagues in other areas, these areas are very much under-documented in most intensive care units, so we're going to go through them briefly. So anemia, it's never the primary reason someone comes here. It's always a secondary condition, and you can see, as we said before, being relational and specific. Why have they got anemia? Actually stating they have anemia, because so many people will come through the doors of ICU and they just get a bit of platelets here, a bit of red cells there, and no one ever says the word anemia or thrombocytopenia, and definitely very few people actually link it with what is the condition. But you know, having post-op bleeding due to surgery, totally fine. Doesn't mean that anyone did anything wrong. It's just part of the course of some of these procedures and interventions. And naturally, sepsis causes myelosuppression. So anemia due to severe sepsis or septic shock, super common in critical care. So what we're asking you to do is simply to state anemia and ideally put due to the condition that's there. Any comments on anemia?
Yeah, I think that's very true, Andrew. I think it's a common condition, and often we kind of take it for granted, and we assume that it's low hemoglobin, it's anemia, right?
Yeah.
And I think again that comes to the approach of assumed knowledge, but it is not that difficult, and we have to be explicit mainly because there are multiple reasons why the patient could be anemic, and that is important for us to articulate very clearly so that everybody is on the same page. And it is going to take an additional minute of your time or our time when you're doing it, and that's what we have been trying to educate our staff members, that it's not asking for anything major. Just that extra minute to put that information there, and it will be a whole lot better, not just from an AVF point of view, but for patient care.
Absolutely. So here's just some basic examples. Someone's admitted for 4 days with a GI bleed and acute kidney injury, and it just says hemoglobin 99 and doesn't have a specific. We're not actually transfusing that, which is fair. So that would actually come out a minor complexity of $1,900. Don't worry about too much about the money, but it's just telling the story of the value that's there. And then if you compare that when it says diagnosis of GI bleed, AKI, and anemia, just the addition of the anemia and having something like a repeat CBE to monitor the blood loss will instantly almost triple the funding there up to $5,500. So you can just see how being explicit and specific, going it's anemia due to the GI bleed, and even if you're conservatively managing it, just monitoring the hemoglobin is part of the plan. That's just a very simple way to go. Another one which is really similar to the idea of multi-organ failure is pancytopenia. Hematology love using the word pancytopenia. It sounds intelligent. It captures this picture of overall bone marrow suppression or significant loss of blood products. And unfortunately, it's not specific enough to code. So you can't code pancytopenia, you can't code multi-organ failure, but you can code for specific organ failure, and you can code for any of the 3 main anemia, thrombocytopenia, and neutropenia, specifically cytopenias that are there. So you can see here, if you write, someone comes in under heme for 5 days with pancytopenia, $2,500. If you just say that they came in purely for anemia, thrombocytopenia, neutropenia, this is without even saying they've got AML or whatever it is they've got, $7,000. Massive difference just from being explicit with those terms. So please use them where you can. The other one, just to add, because coagulopathies and thrombocytopenia are much more common in heme and ICU than anywhere else in the hospital. These are a quick list of conditions related to platelets and coagulation that are codable. And you can see here sometimes even coagulation deficit, so that's just coagulopathy, not other specified, or secondary thrombocytopenia, or bleeding due to anticoagulants. Those 3 would be really common in your unit. And so documenting that appropriately will actually capture that complexity. And here's an example of the thrombocytopenia. You can see someone's coming with cholecystitis and sepsis, and they've got an AKI and CKD. They're pretty unwell and in for a week, $5,500, probably not actually reflecting the investment in that person's care. And if you were to say that they've got the same thing and actually specified thrombocytopenia due to sepsis, suddenly you double the income, and because you've gone to the intermediate complexity, and it's $11,000. It's really worthwhile, those 4 extra words, wouldn't you say, Krish?
So, yeah, I think that's an eye opener for me.
Yep.
And certainly, it has been ever since we undertook this journey with improving coding with our clinical documentation improvisation team. The more I think about it, I think I realize that it is, while it is helping the activity part of it, it is actually helping us to unpack some of the issues our patients have, and certainly it makes our thought process very clear. And sometimes we do things in a non-linear way. We start the treatment and then we go back and have a look as to why it happened in the first instance. Whereas what this is actually doing, it is trying to make it a lot more linear, and it is making our thought process a lot more streamlined.
That's great.
So I think that's the way I see this moving forward. And certainly I think the people who are starting it new, it's better to get it right the first time.
Absolutely.
Because when we learn things the other way around, it is very difficult to actively unlearn.
Very hard to change habits.
That's right.
Better to set those habits from the start.
That's right. I think that's why it is important to catch them young and catch them in the right time frame, wherein they're able to embed good practice so that it comes as second nature.
Yeah. I won't show you examples for every single one of these top 5, but is the coagulopathy example here. So you've got liver cirrhosis and liver failure, aka on CKD. You'd have these kind of patients reasonably frequently.
Yeah.
If you were actually to say that there's a hepatic coagulopathy there, suddenly you see you've gone from minor to major complexity, and that's more than double the income. Again, it's not about the money, but it's about the money as a value proposition that shows just the complexity and how we value that.
Yeah, I agree with you. And the value proposition is the most important thing. I think we need to respect what we are dealing with, and we need to ensure that the elements which constitute that are included. Yeah.
Absolutely.
Yeah.
So number 1 was anemia and its related conditions. Number 2 is electrolyte disturbances. You all know this, and it's applying the same principle. So we won't spend as much time on this, but very simply, when you think about electrolytes, just actually document what the diagnosis is. Is that hypokalemia? Is it hyperkalemia? Is it magnesium deficiency, phosphate deficiency? That would be the top 4 in acute patients generally, critical care and on the wards. So actually just saying it rather than potassium equals 3 or potassium equals 2 or potassium equals 7, those things, we all have emotional responses to those numbers, but that's an inference like we talked about before. Instead of assuming and inferring things, we just need to explicitly say what it is. So we go K equals 2.6, hypokalemia, transfuse IV 30 millimoles. So that's the plan. And if there's any complications, which is particularly cardiac when it comes to potassium, but there can be other complications as well that we need to be aware of. So here's a really traditional and simplified way. A lot of people would just write the potassium and then work the plan. It's missing the diagnosis, so we can't code that. And so very simply, if we could, I haven't really changed much other than writing hypokalemia from high stoma output. So again, the diagnosis due to or from the condition that's underlying. Very simple. Respiratory failure, this is number 3. A lot of people come to intensive care because they have type 1 or type 2 respiratory failure. It's often very clear what you're doing for them. They're intubated, they're on an OV, they're on nasal high flow, the ABGs that are done to monitor that, the outlines that are put in to monitor blood pressure and be able to access those. They're all really clear. So I say well done for those, keep that up. But often that the actual diagnostic part and the rationale is the bit that is lacking or can be improved. And so obviously putting the type 1 or the type 2 in there, whether it's acute or chronic or acute on chronic, even better if that's the case. And then why have they got respiratory failure, particularly type 2, because most people shouldn't have type 2 respiratory failure. And is it from, what's the acute cause, like pneumonia, pulmonary embolism, heart failure, whatever it is. And then what is the underlying condition that is maybe exacerbating this? So COPD, pulmonary fibrosis, obesity, these are all patients that are more at risk of type 1 and type 2 respiratory failure. So linking that together. And then naturally, there may be complications from the actual cause. So if there's septic shock or delirium, a lot of people who are hypoxic become delirious, very, very common. And do they have antibiotic resistance to whatever bug that you've identified? And almost everyone that goes on NIV or comes to ICU does get a degree of deconditioning, and that adds to complexity as well. Any comments on respiratory failure, Krish?
Yeah, I think we have been trying to do this regardless of ABF requirements about mentioning hypoxic or hypocapnic respiratory failure, because it is important that we are very clear in why we are doing what we are doing,
Yep.
and it is helpful for the teams, and more importantly, for our own staff. Like, the morning walk around is being done and the night person is coming, and then we have a very varied skill mix here, and people from different countries, different, training backgrounds.
Clarity, continuity.
Exactly. And so as a consequence, it helps us in more ways than one. Yeah, but certainly agree with all of that. And it is, again, something which we have to embed in our practice because it is a common condition we treat.
Absolutely. I think here's an example. This is a more extreme version, but just so you can see the relationship and specificity. Enterococcus faecium aspiration pneumonia, very specific diagnosis, exacerbating COPD, causing type 2 respiratory failure, delirium and AKI, resistant to amoxicillin. There you're going to get high complexity. The plan, continuing vancomycin. Why? For the E. faecium pneumonia, commencing NIV for type 2 respiratory failure due to COPD. Yeah. So just being really specific, it doesn't have to take a lot of extra time, just really simply having a lot of due to and as specific a diagnosis as you can.
Yeah, the buzzword is due to.
Due to, it's all about due to. If you take one thing away, it's just use lots of due to. Context of, background of, doesn't work. Sorry, you can write secondary to. Due to, it seems really simple. It doesn't sound as intelligent as in context of, but it's what works. So please, as much as you can, use due to. Let's move on to renal failure now. As number 4, lots of people have acute kidney injuries. Very simply, you're seeing the principle happening lots here. Why are they having an AKI? And if it's complex and there's multiple reasons, don't write multifactorial AKI. Please write AKI due to septic shock, due to pneumonia, due to whatever else is contributing, dehydration and the like. And if there's chronic kidney disease, this is something that I still need to improve a lot on, is the stage, because coders can't interpret the creatinine number, even if you write that. You and I kind of have a vibe on what that would be, and the GFR as well. But if you document the GFR or the stage, they can document that. And likewise, if you can write the cause, ideally the CKD, less of an issue in critical care, but just a general principle. And then if you've commenced renal replacement therapy, you always want to link it. It seems obvious, we're assuming. Why else would you give dialysis other than for renal failure? But you need to actually just write it, because the coders can't do the it's so obvious game. They just need to actually have it. Renal replacement due to AKI, or CVVHD due to AKI. And ideally, the specific indication, which, like we mentioned before, vast majority is going to be either fluid overload or severe hyperkalemia in a critical care environment. Just say it. It's very simple. Don't even need to say severe. You can just say hyperkalemia requires dialysis due to AKI, whatever it is. That's really simple. I think I've got an example of that. Here's the complexity. So someone comes in with CKD and hypertension, apparently 2 disparate conditions, just relating them, just calling it hypertensive kidney disease. That sounds more intelligent anyway, doesn't it? I love it. And that just quadruples the income there, up to $4,200. So you can see just a very simple example of that relationship between conditions counts for a lot in the coding world. And here's another one where someone was in for 4 days with a UTI, had acute kidney injury, already has CKD, developed urinary retention, $3,000. Very simply, by specifying that the urinary retention was due to benign prostatic hypertrophy, and that's probably why they got the UTI as well. You could even put that UTI due to BPH. The complexity doubles there as well, because we're more accurately capturing the complexity of this individual as opposed to a simple case. One last example, this is just simply putting dehydration. One of the most common reasons that people come in with an AKI is dehydration. Just state it, due to dehydration, other factors as well, doubles the income because of major complexity. Lastly, diabetes, a very common condition, increasingly so. I'm working up north now. I'm told that's the 3rd highest diabetes area in Australia. That's right. So it's there's a lot of it around. And it really does impact the management. It does impact the recovery period, and it impacts the complexity and complication rates of these patients. And so if we're not documenting the diabetes, we're missing like a really big piece of that puzzle there.
Yeah, I think it's an epidemic, isn't it? And I think we have to be, very careful documenting that. And again, just on that renal part of it, we use different terminologies. Some say dialysis, some say RRT, some would say CVV, either way, I think the fundamental premise still remains the due to.
Yes.
And, if that is, again, the take-home message is due to what?
Due to.
Due to. Okay. All right.
So, diabetes. We all know diabetes. And just applying those principles, specificity, relationships, being clear. Is it type 1? Is it type 2? Is it steroid induced? Sorry, hematology. We love giving steroids. We do induce a lot of diabetes. And then the acute complications, and that's very relevant to their admission. Hopefully that's already been captured. The foot ulcer due to diabetes, poorly controlled BGLs due to infection. So just linking these things due to there. And the chronic complications that may impact their ability and their physiological reserve when they come to critical care with an acute insult. So if they got diabetic nephropathy, diabetic neuropathy, a diabetic retinopathy, vascular disease of the heart, the brain, the periphery, all of these things are chronic complications, and therefore having that, ischemic heart disease due to diabetes and smoking, just really clear there. There's often an association with obesity. Both diabetes can cause development of obesity, fortunately less so with modern therapies, but obesity is also associated with having type 2 diabetes as well. And lastly, just being clear with the intervention. So if you're commencing an insulin infusion, pretty common intervention in the critical care space, what's it for? Just actually saying insulin infusion for DKA, insulin infusion for perioperative hypoglycemia, and the background of type 1 or type 2 diabetes there. Very simple. Just if you spend that extra 10 seconds or so to write that extra, you'll really capture that complexity. In summary, today we've covered some specifics around intensive care, and I'd say probably the biggest thing there is trying to avoid multi-organ failure and specifying what the organ failure is and subtyping that and the interventions associated. We talked about the top 5 issues that are under-documented in intensive care being anemia, electrolytes, renal failure, respiratory failure, and diabetes. So thank you very much for joining me, Krish. Any last closing comments that you wanted to make?
Yeah, thanks, Andy. I think it's been a great journey with the scoring team and learning along the way. Apart from all we've spoken about, I think the fundamental premise still remains that this is actually a safety and quality issue. And when I say that as safety and quality, the way I look at it is safety is doing the wrong things less often and quality is doing the right things more often.
I like that.
Okay.
Yeah, that's good.
So, the quality here is like, due to, being explicit, being specific, and trying to create that connection, that being relational. All of that is actually good things and we should do more often.
Yeah.
And that is a good quality initiative. In terms of the safety issues, I think we can say that if you're not going to be documenting properly, we can actually put patient safety at risk.
Absolutely.
And that's the most important thing for us to take home as a message. And I think we'll continue to, foster this good practice. And once again, thank you.
Thank you. Thanks for watching.
Thank you.